Okay. So what are your thoughts on yesterday's program?
Okay.
Because this is the first. I'm listening.
It was okay overall, but certain areas like clinical skills, interpretation of some of the symptoms, I think they can learn more. Like I wanted to have some clarity. Remember prosthetic wall, mitral regurgitation, and bioprosthetic wall and endocarditis suspicion.
Yeah.
And what was the duration of symptoms of that patient before he had surgery? I thought it's more than 10 years or 12 years.
The first surgery was 12 years back.
Symptoms
were mild symptoms for 12 years.
Yes.
Before the first surgery, worsening symptoms for about a week.
Yeah. See, that's what I wanted. See, we are always taught, right from our student days to now, that any person who is significantly symptomatic for more than 3 years, usually it is mitral valve disease. It's not aortic valve disease.
Yeah,
somebody is symptomatic for 12 years and then had surgery, that rules out aortic valve disease because they don't survive that long.
Once they become symptomatic, they don't survive that long.
That's what I meant. That issue was never brought out.
Yeah, sure. Actually, I was talking to some of the students yesterday. So they were telling that instead of having 1.5 hours continuous discussion, we will have the case discussion for about 1 hour 15 minutes. The other 15 minutes, the students have got a lot of queries.
I know.
Which they felt that they were not discussed adequately, or at least they were not satisfied with the discussion. So I thought today, for 1.5 hours discussion, we'll make it 1 hour 15 minutes. And for the 15 minutes, we will leave it to the students to ask them questions and get clarifications, whatever they want. I think that is what yesterday I was talking to about half a dozen students and participants.
I also wanted your inputs. Srinivas, how are you?
Morning, sir. Morning.
One of the students yesterday presented JVP in supine posture, level and wave pattern is normal, he said. Then, see, JVP, neither level nor wave pattern can be made out, should be made out in supine posture because it goes intracranially. The height of waves cannot be seen. And there used to be a joke that if you want to measure JVP in supine posture, you have to do craniotomy.
Dr. Dayasagar Rao, another thing I observed is, I think during the case discussions when multiple faculty members are interacting, it is good to have, particularly on the web, it is good to have a coordinator or some kind of a leading
1, 2, 3
discussant.
1, 2, 3
he can call up the faculty one after another for opinion, but here there was a lot of clash of talk, sound, etc. Crosstalk, there was too much of crosstalk. That can be avoided by having an anchor person.
I think Dr. Dayasagar should take over that.
Anchor, you can only control a disciplined crowd.
No, they need to be disciplined.
Not because they want to make noise, but that coordination is needed.
Sure. But I think one of the things what was I was happy was the transmission of audio and video was quite okay. About 99% it was okay. Occasionally there was some echoing in one of the rooms and there was some dropping of the audio on 1 or 2 occasions. Barring those 2 occasions, I think it was quite okay.
The echoing was because of Dr. Suday Kumar and his student were in the same room.
In the same room,
And both of them were using 2 independent mics. So there was echoing because of that. When I pointed out, they switched off.
Yeah.
But that was only brief for maybe a couple of minutes.
Yeah, exactly. But I think another thing what I noticed is the people or the consultants or the faculty who are doing it from their respective rooms, it has not been shielded from. So there was somebody in the backdrop yelling and shouting. Kids were making noise. So I thought, probably, one thing what I have told the faculty is, if you want to have that kind of noise muted, you just mute your microphone and still you can participate. You can listen to them. But whenever there's a background noise is very high, you can mute your mic and then still participate in the meeting. And whenever you want to talk, you can unmute it and then talk.
But overall,
and also,
ask me, overall, because this type of experience we are all going through first time, and
exactly.
It went on well, actually.
Fair. Reasonably well. I thought there will be a lot of hiccups, today. So,
second thing, Dr. Dayasagar Rao, there wasn't enough opportunity for the students to interact with the faculty.
Sure.
So I think we need to give a window of opportunity to them to raise some relevant questions and listen to the faculty.
Sure. And then actually that's the reason why I said today for the case discussion for 1.5 hours, which I put it, we'll have to end the case discussion in 1 hour 15 minutes. And the last 15 minutes have to be given to the various students or whatever queries or whatever clarifications they would like to have. So I thought that's one of the ways of doing it. And even today also, I have asked some of them to volunteer because the case discussion probably may not be that important. But in the arrhythmia session is there by Dr. Narasimhan is there. He is going to have that. And then there's also going to be some case discussions in the peripheral arterial disease. So there are about 3 or 4 occasions. For example, interpretation of the coronary angiogram is being done by Dr. P.K. Goel from SGPGA Lucknow. So in that also they will require some volunteers to read the angiogram properly, appropriately, not just telling that 80% block in RCA or something like that. There's a systematic way of interpreting and reporting of the data. So I've selected about volunteer. So we thought we will just tell the speaker that these are the volunteers, like what I did in the morning, first session with Dr. Sathya Murthy. They were willing to volunteer and then they were willing to participate. Today also we are going to have something of that kind during the case discussion and also during the interactive sessions of arrhythmias and angiograms.
Spotters are also there. Spotters are also there.
Yeah, spotters are there. Last one, that is, I have kept the prayer, last just to maintain the attention of the audience or the exam going students, which I am told spotters are going to be the thing for them this time because of the way in which we are placed because of COVID infection. So they are all very keen to participate in the spotters. So we will see. Instead of 10, I said we will have 20 and then we will see.
I myself have 25.
Yeah. Okay.
But they're all CT and MRI.
Yeah.
That's spotters.
That's fine.
And do you have a panel of students who are going to take up the spotters?
Yes. We have, I think, about 6 or 8 people are there. So I'm going to put them as 1, 2, 3, 4, 5, 6, 7. And then the faculty, whosoever is wanting to discuss, they can call volunteer number 1, and then they will have to...
Give us the names. Give us the names of the volunteers.
Sure. I'm going to give the names. Okay. Srinivas Kumar? Srinivas?
Sir, morning, sir.
Yeah, good morning. Are you ready with your this thing?
Yeah, I'm ready.
Okay, then. I think without much ado, by the way, there were yesterday's total, participants. It is also being recorded on the YouTube. I made it recorded on the YouTube. I'm told by the Sun Pharma that yesterday there were about 290 in this Zoom and then about 60 on the YouTube. I'm sure, today also there will be enough. Probably there may be more today because it is Sunday and then we are starting early. You can go ahead and then start your talk, Dr. Srinivas Kumar.
Yeah, good morning, everybody. Indeed, it's pleasure and honor to talk in front of my teachers. And then thanks for this opportunity, Dr. Dayasagar Rao, sir. When I first saw Dr. Moderator and Krishnaraj, I was surprised actually. Thank you, sir, for joining in. You people are role models for younger generation. You see, only 30-40 of younger people join, but all of you are there on time and start everything on time. That's what we have to learn from all of you. Thank you again. But topic which I was asked to speak by Dr. Dayasagar, actually angiogram would have been first, then this would have been next, that would have been better. Anyway, for various reasons, what I was supposed to speak on intracoronary imaging, intravascular ultrasound and OCT, how they help in diagnosis and management of patients. I think what I thought it's basically a fellows course and I thought I would cover more of basics. I request all the seniors to excuse me for covering up these basics. And this is again a little statement I wanted to make because students nowadays students and younger people also do a lot of things. Some of the things we do may have no scientific basis and have a significant bias. Suppose if I am interventional cardiologist and each of us could have our own biases. But the more we do, we learn more. The more we practice, the luckier we get. Many ways to reach the same goal. The goal is again to do what is good for the patients, but never compromise on what is good for the patient. Try and do what is good for the patients to the best of our abilities and efforts. I just wanted to make this very clear because people do imaging and then without acting on it just for the sake of doing it, it's not the right thing. So what is good for the patients, we need to always practice and encourage this in juniors. Best wishes from Apollo Group of Hospitals. Proud to present my fax professional service colleagues which run in hospitals in multiple in a hub and spoke model. This has been very useful, especially these tough times of COVID, helping each other and also getting referral patterns for TAVR and other programs which have been effectively being done. Coming back to the agenda of today's talk, I just cross-checked with Dr. Dayasagar again whether I have 1 hour's time. He said entire 1 hour you can talk. So I thought I'll talk for about 50 minutes, cover initially about, this is the agenda, what I would do. Basically introduce and then present some of our NIC data, which I was fortunate to collect, and tell you briefly about pitfalls of angiography and advantage of intracoronary imaging. The types of imaging, obviously, we know these two are presently practiced. Cover up IVUS in the first 20 minutes or so with basics and image interpretation. Am I audible, sir? Is it okay?
Yes, you are very much audible.
And then show you some case examples for comparison. And then try to simplify the OCT, cover up the basics of OCT like MLD max concepts. And then show you some examples of left main and how this imaging helps in bifurcation case examples. And if time permits, I'd also show some multivessel disease cases. And then in the end to conclude. This is, I was fortunate to collect our data in my alma mater, SGPGI. This what is presented. You see this huge number of cases, 438,351 cases got collected in our country, and out of which left main constitutes about 2.5% and single vessel, multivessel are shown there. And what is relevant for today's talk is the imaging. It is quite heartening to note that significantly increasing number of centers are doing imaging. About overall 4.2% of these cases imaging help was taken. It's quite less compared to what is recommended in the worldwide, but at least we are progressing in the right direction. The strength of India is the 4.2% becomes 18,514 cases. So that's where if we can team up ourselves and then probably get out good data, it goes a long way. Left main imaging, again, about 35% of left main imaging help of imaging was taken. So that is in brief about our country's data or whatever we could collect. Coming to the pitfalls of the angiography, if it is a central concentric lesion, there is no problem. But if the eccentric lesion like this, if the image go like we take a RA view, it may not show any lesion at all because the lesion is there on the other side. And if you see, if it's coming like this, then you could overestimate also. So whenever the lesions are eccentricity, we know the problems. When the concentric lesion is like this, whichever view disease like this, you could see it in one view and you may not see it in view tight, and other view you may not see it. On the other hand, if you have some eccentric and lobulated lesions like this, we could miss out totally, and we can think that these sort of things we were missing in angiography era before. So these sort of things we became more wiser once we have the imaging. I always ask this question to fellows: if the lesion is seen like this in one view, like mild in another view, which we should take? Probably we will find more answers to this in the imaging talks further. Then if a vessel is diffusely diseased, again, sometimes we underestimate, and because the reference segment itself is diseased. So these all we know when we are seeing the exact vessel diameters and the imaging. The positive remodeling concepts and negative remodeling concepts also started becoming clear, more with BVS era coming up, and the arteries tend to dilate themselves and try to adjust the lumen. These sort of things all we became wiser after this. If you see this, proximal LED, somebody had stented with 2.5 stent, which is grossly underdeployed for this. If you really see the measurements in this, it is 4 mm there. So, and obviously the patient comes back with restenosis. This was more in presence of proximal LED disease and the vessel diameters being estimated very small. Angiography versus IVUS, if patient has diabetes and the patient has proximal lesions, there was more of discordance between patients who had diabetes and the proximal vessels compared to the distal vessels. So that's why the proximal vessels, especially when you're doing left main, it is more relevant to do intravascular ultrasound. Some of the advantages compared to intravascular ultrasound are mentioned here. The great is the quality of pictures and what we have inside the lumen, also inside the walls, we can make out by intravascular ultrasound. But the strength of angiography, it is extensively used since last 60 years. Entire coronary anatomy, including the flow patterns, can be seen well. All of us are more comfortable with it. And it has a lot of positive predictive values and correlated well with QCA. And we all are comfortable in clinical decision-making process. But the bad things about angiography, as I've shown, eccentric stenosis, we tend to miss it. And smaller dissections, and then again, we don't have too much of correlation with physiology, though we have some studies which have come out. So these are the good and bad about the angiography. Coming to the IVUS, the good thing about IVUS is basically the vessel wall, not only the wall and inside the lumen visualization is possible, and the plaque characterization, that's how which plaques tend to worsen, which all that information we have more with this intravascular ultrasound. Then, but the negative thing is actually we need again have a separate machines, and then the cost of it and the cost of the catheters, and then while doing also you need to take precautions and have that expertise. Then another pitfall of IVUS is basically what is mentioned is disadvantages. The catheter tends to image always in the circular perpendicular pattern like this, but sometimes you could get pictures in this oblique pattern, overestimating the vessel diameters and sizes. We need to be careful about it. So in this comparison, basically, angio is most widely used and convenient. IVUS actually helps us to understand more better within the lumen and the walls. But we need to understand the pitfalls of each of them and use it appropriately. Now let us a little more deep dive into intravascular ultrasound. As I said, IVUS is a technology that allows in vivo visualization of vascular anatomy by utilizing a miniature transducer at the end of flexible catheter. IVUS, again, this is basically an ultrasound machine which has developed an interface and connection, and we are able to see within the coronary arteries. But if you see, that's how the catheter goes in and you visualize the artery like this. Then if you see, the first use of IVUS was done in Rotterdam in 1971 by Baum. It was actually done for visualizing cardiac chambers. And later on, luminal images were seen by York, and from 1988 it picked up, it evolved like this. And now a lot of developments are happening further in the imaging. This is the console. Just for sake of juniors, I thought I would just show some of them who are not exposed. Then probably these are two types of catheters again, phased array and mechanical catheters. Now both have its advantages and disadvantages of mechanical catheters, and phased array catheters are mentioned here. Not required to go into all the details, but basically this catheter gets mounted in rapid exchange fashion through the regular wires what we use, and then you get the pictures like this on the machine. If this is a picture which we took recently from one of these patients. This is the regular wire which it goes, and this is the threading of the IVUS catheter. while you image, then you come back. So you have both mechanical as well as automatic pullbacks by which you image. This is what I was mentioning. As it goes inside, it's actually supposed to take the pictures exactly in the cross-sectional way. Sometimes you could also get an oblique fashion. So that's what we need to be careful. But by and large, in the smaller vessels, it tends to take it okay. This is another picture in which, just to get an idea, as you come back, pull back, you see the entire vessels, lumen, and the plaques are mentioned here. I would show you some still pictures later while explaining. So if you see this, this is the central is the IVUS catheter, and then this is the in plaques, and then you also get into you can measure exactly the plaque volumes, and that's how the regression studies are also seen. If you have to see it in a little more detail compared to how it compares with the histology, what we have is the intracoronary image of the artery, a bright echo from the intima. That is what is eye is what is intima. Then you get multiple bright echoes outside, that is adventitia, and then the media looks as a central dark zone in between. So this is the comparison with histology with IVUS, and in good quality pictures you get like that. And this is a little more higher view of pictures of various layers in the artery. So if you have to see the atherosclerotic plaque, what we want to know is the plaque extent, morphology and composition of the plaque. And then our capability is, again, not only visualize the plaque, but we want to see beyond that also. And sometimes some of these terminologies I thought, people should understand. Basically, the penetration, again, depends upon a number of factors, including the power of output of transducer and imaging frequency. And dynamic range, many times it is expressed as this 17 to 55 decibels. That basically tells us which is the weakest and which is the strongest targets in which it's seen. Resolution is another important concept which we need to understand. Basically, there are three spatial resolutions of resolution is there. The resolution is basically the ability to discriminate two closely adjacent objects. Even if they're close, if you're able to make out separate, that means it has a very high resolution, which OCT has compared to IVUS. Then resolution could be axial resolution, circumferential resolution, and the lateral resolution. So we need to understand these concepts of regarding resolution, and some of the artifacts which you get also we need to know. This is a ring down, refers to disorganization of image. If the catheter is close to the wall, you tend to get again, I supposed to be in the central location. Sometimes you get those artifacts. Node artifact is again happens most with mechanical transducers. This is some of the portions of the images appear stretched. And then the side lobes and the reverberation artifacts caused by false echoes of the intravascular ultrasound. Whenever you find air bubbles, again, you get a very weak image. When you find like this, you need to flush the catheter well and then do re-imaging. Then perivascular landmarks help us to identify what is the vessel. But generally, we know by the angio also what vessel we have put in. Pericardium looks like this. Then the catheter guide wire in the central looks like this. And then LAD, if you have to identify, we are very comfortable seeing the angiograms, but we also need to know adjacent structures so as to identify these vessels. And this right and left interventricular veins, besides it tells us that is LAD, and the diagonal origin also tells us. Then the pericardial triangle, when you come more close to the LAD LCX, you make out that you are imaging the proximal portions. As we understand that LCX has close proximity, it runs in the AV groove. And if you see it, the great cardiac vein besides it, if you see the channel, that is again, we can say it as LCX. Right coronary artery, again, the same thing on the right side happens, marginal vein C on the right. And it's also important for us to make out from the branching patterns. So that's about identifying each of these artery and some of these normals and abnormals. What IVUS evolved further is you get a transverse plane cross-sectional views, but series of multiple fusion of this cross-sectional views can become a longitudinal view like this for us, and that's what the computer does and shows it. And the advantage of it is you can reconstruct the artery entirely to the entire extent and make out the total atheroma volume from a particular point to particular. So this is what is the characteristics what we see. This is the lumen area, this is the plaque area. We can calculate, and the percentage of plaque area which we get here, it's all calculated. And as shown below, you can trace it at any particular point, you can calculate it, and you can identify what is the normal to normal, and then plan the stenting procedure accordingly. Some of these confusions happen when you see such occlusant structures, whether it is an artifact or within. Some of the pointers for youngsters to note is if it is happening within the plaque like this, if it is an occlusant, generally it is unlikely to be an artifact. It is likely to be a plaque which has a soft plaque with inside such things. It refers to as a little unstable plaque. Soft refers to low echogenicity. Then you see a dark spaces there. That is a soft plaque. Whereas fibrous plaques, again, you see it as hyperechoic regions there. And most of the plaques, what we see in day-to-day practice are fibrotic plaques. Then this is where imaging helped a lot, identifying the calcium dyscalcific disease. But the only problem with this calcium with the IVUS is once the ultrasound hits the calcium, you don't see anything behind it. It becomes dark. So if you have the length of the circumferential calcium extending all across, then probably that's where you need to take the help of rotablation and prepare the bed properly. But if the calcium is extending only to 1/4, less than quarter, and if the thickness is very less, that aspects will cover in OCT, because OCT is showing the depth of it very clearly. And then the calcium is superficial or calcium is deep inside like this, all this we can make out very clearly by imaging. Then some of this intraluminal, what we said is in the plaque and in the wall. Now some of the structures which see in the lumen of the artery like this, then probably within the lumen, obviously most of the times we end up with thrombus. But sometimes within the after you do stenting image, it something protrudes inside it. That is the plaque protrusion which could happen. And these are we need to understand this, and then probably also if there is a gap in between, we need to tackle that by further post-dilatation. That's where the role of it comes in intervention. False lumens sometimes you also tend to get into, especially in CTOs and other problems. Aneurysms, and especially when drug-eluting stent era, you could get true and false aneurysms. These are some of the pictures which you see. And the black holes is generally it's outdated now. You're supposed to be seen in brachytherapy era. This is where I think all the youngsters should concentrate and see. After you put a stent, if there's a lot of gap in between the wall and the stent, when you undersize the vessel with a smaller size stent, you alleviate a lot of gaps there. The stent apposition, it becomes incomplete, high chance of stent thrombosis if you leave it like that. That's where we need to work on, put a high pressure dilatations and do it. These are scientific statements come from ACCHA and many other organizations to how to interpret these images and how we need to express the diagnosis of intravascular ultrasound. I would just briefly mention about this. We take from leading edge to leading edge. What we need to calculate is we need to calculate the proximal reference segment, that is the largest lumen proximal, and distal reference segments go beyond the lesion and calculate distal reference segment. And probably average of it is what we stent select size, and the type of the lesion and type of plaque inside we need to see. So as I've shown in some of the pictures, what we measure is we measure the cross-sectional lumen area, minimal lumen diameter, and the maximal lumen diameter. And whether the eccentric stenosis or concentric stenosis, what is the area of stenosis? I have shown 65% in one of those pictures. And you can make out clearly like that regarding the plaque morphology. If you see it here, again, this is the lumen area which you have it inside. Then this is, if you see the entire extent of the vessel wall here, that is the adventitial is beyond it and media to media. That is where you exactly measure the plaque volumes and the intimal thickness. And then you tend to measure totally. And that's how this expression of the reporting of intravascular ultrasound has to be done. You see, whenever you find appropriate patient demographic information, we need to write. And we need to have indication for procedure. Why are you planning to do the procedure? Whether it's a diagnostic imaging for assessment of stenotic severity, or you are taking the help of it for intervention. Then brief description of the IVUS procedure, what type of catheter we use, what is the anticoagulation we gave, and what are the coronary arteries which we imaged. And basic findings of the IVUS pullback as a broad you mentioned, from what area to what area we have calculated it, and the plaque morphology, presence of dissections, calcium thrombus, we should go in more detail into plaque morphology. And then after doing the IVUS in the procedure, what is the outcome change which you have decided? That is whether you are dilated with a more bigger sized balloon and what is the approximation like later, all that. And if at all, if you have any complication like spasm or other problems related to it and how you tackled it. These are some of the things which are descriptive way of using IVUS reporting. I thought I'd briefly mention for the sake of all the youngsters. Nowadays, the reporting patterns go, as Sir was telling, they write only 80% RCS stenosis, not much of details. Similarly, the IVUS also is just done and not much of reporting is done for this. I thought I should mention this proper reporting of intravascular ultrasound. I'd briefly go into some of these studies, but I won't bore you with all these deeper studies. This made us capable to identify the entire extent of the plaque. And that's how this asteroid study, the plaque morphologies, the regression patterns, how it happened with statins is again made out. And these are some of these newer modalities of imaging like virtual histology tells us that how the plaques are getting stabilized, but some of these did not become very popular with the advent of OCT. Then a lot of interest in the intravascular imaging is the identification of vulnerable plaque. And these pictures, cartoons, you know very well. Initially, people have tried this vulnerable plaque ruptures, all the documentation, the various types of plaques. And our idea was to identify before somebody becomes unstable and suffers this ACS and acute MIs. The soft plaques, the fibrous plaques, and the superficial calcium, deep calcium, all that is shown. Then what people have said is if the plaque is unstable, then probably you would have areas of like necrosis and spots and spotty calcium there. And this sort of ruptured plaque cavities could tell us that plaque is becoming unstable. So the eccentric nature, positive remodeling, ulceration, thrombosis, and spotty calcium tell us that plaque is a little vulnerable. This is again helps us in identifying, preventing events on the follow-up. This is one of the study published before, again showed the presence of spotty calcium and eccentricity and positive remodeling will help in identifying. Then atheroma volume burdens, the various trials have used it to calculate regression studies, and especially when high-dose statins, this has become possible. The prospect study, again, took the help of as identifying the thin cap fibroatheromas, and people have compared ultrasound with CT. All these, I would say, is a relatively older studies because a lot of new information is coming up with more advanced modality of imaging with OCT. Coming to some of these interventional things, what we want is pre-intervention. We want to see the accurate quantification, assessment of reference segment, strategy for device selection, instant restenosis. Again, we found out what it is. And ambiguous appearances post-intervention, then probably as incomplete apposition, balloon, further angioplasty, high pressure inflations. We have these are the interventional indications for intravascular ultrasound. So instant restenosis, it made a lot of difference for us to understand the pathology of imaging, and then a lot of solutions we are trying to find out. And whenever the areas which you get after the procedure are less than 4.5, then probably there's more chance of patient getting into restenosis. And expansion patterns also, if there's under expansion and more than 50%, then you tend to get into restenosis. That's what some of the studies show. But whenever you do a procedure and post-intervention, you get areas of more than 10, there's a very minimal chance of getting restenosis. If the stent areas are less, then again you have a higher chance of getting into restenosis. Then left main also, you have the similar patterns, because why stress separately is left main imaging has a lot of importance with intravascular ultrasound, especially the ostial type of lesions are better seen with intravascular ultrasound compared to OCT. The true vessel diameter we can measure by this ultrasound. Then post-intervention, again, the same things which apply for the regular vessels also apply in the left main, more so here. And we always want to get better volume, diameters and areas. Now we have a lot of data coming up with IVUS compared to angiography that IVUS patients do well. And what is the criteria for full optimal stent deployment? We need to get at least more than 7.5, more than 10 is better. And we need to have less of stent under expansion. And these are some of the older studies which actually were with IVUS. The OCT ones I'll cover up new. But what it showed is basically whenever we also became wiser that drug-eluting stents have better, less restenosis. And areas, if it is less than 5.5, lengths being more than 40, now it became 60 with the better quality stents, the chance of restenosis could be high. This is the first study where it identified with Cypher with imaging. I just thought I'd project that. But basically, it tells us exactly what is the areas we get and what is the stenosis residual and what it happens on the follow-up. All these has become possible with imaging, unlike with only angiogram. This is another study, again, restenosis even with venous grafts, showed how the neointimal hyperplasia happens, how it is different between bare metal and sirolimus. All these are older studies with IVUS, but some of the newer ones I will do with OCT. Some of this imaging also helped in understanding this pathology of heart transplant patients, where in angiography they were finding it all okay, but when you did imaging, the diffuse atherosclerotic process was noted in some of these studies. It's not very relevant for us, that's why I'm going faster. And the three-dimensional reconstruction, color coding, and this virtual histology didn't work out much for intravascular ultrasound. So to summarize the clinical utility, what we have learned is basically assessment of intermediate coronary lesions, and then left main lesions, especially ostial lesions, and then assessment of serial stenosis within a single coronary artery. We also had seen some data with bypass grafting, bifurcation lesions, and then guidance for some of the bed preparation of angioplasty, where the calcification and how the arteries are prepared, guidance for stenting, what size stent we take, and assessment of restenosis, how this imaging helped. And didn't show examples of CTO for sake of time, but again, it also gives us some understanding how to cross with the different type of wires. And identification of vulnerable plaque and prevention of future events is what we also tend to aspire, though it is not very clear in all the patients with imaging. So this is about basics of IVUS imaging reporting and what we want. I will show some examples of each still pictures, because the moving pictures will take a lot of time. So, and then go on to OCT later. If you see thrombus versus calcification, and you'll see this lesions plaque morphology there. The second, when I press it, you get the answers for it. Initially, I thought it should be interactive, but that technology is not allowing that. I said I'll show it myself. If you see this, the image for interpretation, you have dissections, fibrous plaque dissection extending into intima, and various modalities of dissection where to address. And the dissection is more deep and more circumferential. Probably we need to take the help of another stent and patch it up. There are minor dissections, then probably you can leave it. Then this is a horseshoe type of dissection, fibrous extending deep into the media, and you also get into hematomas in the artery. Then probably you need to definitely patch them up. This is again what I've mentioned is grossly underexpanded or undersized stents. If you see a lot of malopposition there, and if you dilate it well, again you oppose them well. These are some of the examples, and some pictures of intravascular ultrasound in acute MI, though we don't use it that commonly. Plaque ruptures, which are again seen acute situations, we can also make out in this. I think with this I will stop. If any questions on IVUS, like we can take. Otherwise, I'll go on to OCT.
You can move along to the OCT, and then at the end.
Sir. I will just open that slide. Give me 1 minute.
Yeah, sure.